Okay, we're going to be looking at the cardiovascular system today of the blood vessels, overview of arteries and veins. Remember, blood vessels are what transport blood to tissues. That's where your gases, nutrients, and waste are exchanged. Then they're transported back to the heart. Other functions, they regulate blood flow to your tissues. They control your blood pressure. Also, they secrete a variety of chemicals like nitric oxide, depending on tissue needs. Okay. There's two circuits in the body. One is called the pulmonary circuit, which transports blood between the heart and the lungs. The other is called the systemic circuit, which transports blood between the heart and the rest of the body. So your pulmonary systemic circuits are both composed of three vessel kinds, and those are the arteries, capillaries, and veins. Your arteries are described as your distribution system. They travel away from the heart. They branch into smaller vessels that supply your tissues with blood. Capillaries are your exchange system of vasculature. They generally are very small diameter vessels. They form these branching networks called capillary beds. This is where your gases, nutrients, waste, and your other molecules are exchanged between your tissues and your blood through your capillary walls. Many of the capillary walls are only a single cell thick. Your veins are your collection system of vasculature. They drain blood from the capillary beds and return it back to the heart. They follow the opposite pattern of the arteries. The small veins merge to become larger veins to progressively larger as they progress toward the heart. So the three layers of an artery and a vein are your tunica intima, your smaller lining layer, which is just simple squamous endothelium, which is your lining layer. This is what's adjacent to the lumen. The tunica media is what contains the smooth muscle. And then the tunica externa is your outer connective tissue layer. The tunica intima, consisting of endothelium, is continuous with the inner lining of the heart, which is the endocardium. And these endothelial cells provide a very smooth surface over which blood flow can flow with a minimum of friction and turbulence. You also have a very thin layer of subendothelial connective tissue called the intraelastic lamina, which is below the endothelium. Now, the tunica intima will contain these little vessel properties called distensibility, ability to stretch, and also when they're subjected to increased pressure, and they also have elasticity where they can recoil back to the original size whenever a stretching force is removed from the vessel wall. The media is your layer of smooth muscle cells that are circularly arranged around another layer of elastic fibers called the external elastic lamina. And it's the tunica media that control the diameter of the blood vessel wall, and therefore the amount of blood flowing to the organs. Also, you have tunica media, smooth muscles that are innervated by your sympathetic vasomotor nerves. When these nerves stimulate smooth muscle, the tunica media, they contract. That's called vasoconstriction, which narrows the diameter of the vessel. When the sympathetic stimulation decreases, the cells relax and the vessel diameter increases. That's called vasodilation. And then the tunica externa is your tunica adventitia, is dense irregular connective tissue. And that helps support the blood vessel and prevents it from overstretching. Vasa vasorum are the tiny vessels supplying the media and the externa. They also supply the oxygen nutrients to the outer layers of your larger blood vessels because those cells are too far away to receive adequate oxygen nutrients by the blood flowing through the lumen. You see this inner epithelial tissue lining, a layer of connective tissue, another layer of smooth muscle, and another additional outer layer of connective tissue. You see this pattern repeated in many of your hollow organs in the body. So this is your structure and your function of your arteries and veins with your three tunics, your tunica interna, tunica media with your smooth muscle, and the tunica externa, which is collagenous connective tissue. Most arteries have a thicker tunica media than what veins have, and that reflects the artery's greater role in controlling blood pressure and blood flow to the organs. Also, in your arteries, you have a greater internal elastic lamina. They're much more extensive than what you see in veins, and that reflects the property that arteries are under much higher pressure than what your veins are. So here's an artery on the left showing you the three layers, the tunica interna, media, and externa. Because the artery is elliptical, and it's got a much more well-developed tunica media, smooth muscle in the middle layer, whereas the veins generally have a larger lumen, but they have and the tunica intima is basically comparable to the tunica intima on the artery, but the tunica media is much less extensive than what you see in the tunica media in the artery. And also you have this kind of serrated appearance, this irregular appearance of the lumen, kind of a scalloped appearance. But the same three layers are present, but much less tunica media in a vein than when compared to an artery. So your artery wall depends on the artery size and function. The thickness of the artery wall depends on what it's the artery size and its function. And it's used to classify arteries and based on their similarity. Three classes of arteries: elastic, those are the largest arteries like the aorta and its immediate branches. Muscular arteries, these are the distributing arteries like the renal artery and the hepatic artery. And then the smallest of the arteries are the arterioles. Okay, continuing on, elastic arteries are your conducting arteries. They have the largest diameter. They include the aorta and the immediate branches of the aorta nearest the heart, and they have the highest pressure of the vessels in the entire cardiovascular system. Your muscular distributing arteries are generally intermediate, and they generally feature a well-developed tunica media. They're usually named for the organs that they supply blood to, like the renal artery and the hepatic artery, or the mesenteric artery that supplies blood to the GI tract. Arterioles are your smallest of your arteries. Okay. They generally have all three layers of the blood vessel wall, but layers are extremely thin. The smallest arteries or arterioles are called mid-arterioles, and they generally have smooth muscle cells that are confined to a valve called a precapillary sphincter, then which leads to a capillary. Certain arteries also play an important role in monitoring blood pressure and detecting certain chemicals in the blood. Pressure receptors or baroreceptors, these are found in the aorta as well as in the common carotid artery in the neck. They are also present in the carotid artery and the aorta, called the aortic bodies. These are groups of chemoreceptors which detect blood oxygen levels and carbon dioxide levels, as well as hydrogen levels. Okay, now veins typically outnumber your arteries, and their lumens are generally have a larger diameter, average diameter. Veins have a few characteristics that distinguish them from arteries. Approximately 70% of your total blood flow is located in your veins at any given moment. And that allows your veins to serve as blood reservoirs or capacitance vessels. And that's because the blood can be diverted from the veins to other parts of your system, depending on the body needs. Veins typically have much thinner walls, much less smooth muscle, and larger lumens than arteries. This is a pie distribution of your blood supply. It shows you the systemic veins carry about 55%, and whereas your arteries contain a smaller percentage. Now, venules are the smallest of the veins. They're analogous to the arterioles from arteries. They're the vessels that drain blood from your capillary beds. You also have these tiny postcapillary venules, which are just a little more than endothelium with a little bit of connective tissue surrounding them. And these allow them to exchange material with the surrounding interstitial fluid more efficiently. Also, your three tunics and veins become more distinct as your venules become larger venules and then become actual veins. Veins will also have a thinner tunica media with very few smooth muscle cells, and their diameter will only change slightly with constriction and dilation of the vessels. Also, many veins contain venous one-way valves, which are extensions of the tunica intima that overlap and prevent blood from flowing backward in your venous circuit. Especially numerous in your veins of your legs, where your blood flow toward the heart is strongly at gravity. So table 18.1 shows a typical artery and vein, and their characteristics. As you can see, the arteries have a larger diameter, between 2.5 to 1 centimeter, and a well-developed tunica media, and a well-developed elastic lamina. That's the term elastic arteries. These include vessels like the aorta. And then you have your muscular arteries or your distributing arteries, which have a well-developed tunica media. And these are what control your blood flow to the organs and regulate your blood pressure. And then your arterioles, your smallest of your arteries, have very thin walls with all three layers. Okay, and they are the vessels that control blood flow to the tissues and feed the capillary beds. And then the venules, smaller venules will have generally only a tunica intima, and then your larger venules will have the three tunics, but you only see just endothelium in your very small venules. And then your veins will have one-way valves and very little smooth muscle. Okay, and they, of course, return blood flow back to the heart, the right atrium. Atherosclerosis is the leading cause of death worldwide. It's arterial disease that affects your large and medium-sized muscular arteries. It's characterized by formation of atherosclerotic plaque, which is a buildup of lipids, cholesterol, calcium, and cellular debris within the arterial tunica intima. It's that inner lining that becomes damaged. Plaque will generally form in regions where your blood undergoes sudden changes in velocity and direction of blood flow, where you would see, and what you would see in the branching points, like in the carotid, where the common carotid artery branches into the internal and external carotid. This is an illustration or a photograph of an atherosclerotic plaque that's developing in the tunica intima of this medium-sized artery. There is evidence that plaque generates in response to some sort of cellular injury to the endothelium by high blood pressure, certain types of cholesterol, especially your bad cholesterol, the LDL and the very low density lipoprotein cholesterol, previous infections, toxins in cigarette smoke, hyperglycemia, high blood sugar level, like you see in diabetes, and a high blood concentration of a chemical called homocysteine. And so this is what gives a genetic component to atherosclerosis. So what happens in atherosclerosis? The vessel wall becomes inflamed. That then in turn attracts phagocytes that attempt to clean up the area. But what it does, it actually results in damage to the blood vessel. And eventually that damaged area then turns into a plaque, so plaque becomes located in the tunica intima, but you can see changes occurring in the tunica media. The smooth muscle cells in the media will proliferate, and then they start secreting more extracellular matrix with protein fibers and ground substance that then surround your plaque. So if the plaque then is in turn exposed to blood, your clot may form in a blood vessel, okay, and obstruct the blood vessel entirely, and that's what occurs in myocardial infarction or stroke. MI is basically a heart attack. We know that about 10% of the world population has atherosclerosis, but we really don't know the true prevalence because most patients don't typically display symptoms in the early stages of the disease. Most of the treatments for atherosclerosis focus on reducing the factors that injure the endothelium. These include dietary modifications like changing your diet from a high-fat diet to one that's recommended by the American Heart Association, increasing physical activity like walking and running, agents that lower your cholesterol, what we call the statin drugs like colistatin and simvastatin. Also, if you're diabetic, controlling your blood glucose levels, quitting smoking, and management of hypertension, high blood pressure. In severe disease, surgery, or other invasive procedures may be necessary to either open or bypass the occluded vessels. Vascular anastomoses. These are locations where vessels connect via pathways called collateral vessels. Arterial anastomoses exist in many organs like the heart and brain, as well as your joints. New arterial anastomoses can be formed when your blood flow through the artery is insufficient to meet your tissue's metabolic needs. Your most common types of anastomoses are actually venous anastomoses, and that's when neighboring veins are interconnected. by small collaterals. Your smaller veins are often so interconnected that they form complexes or in web-like patterns. Okay, and then you also have other vascular anastomoses like arterial venous anastomoses, that where an artery empties directly into a vein without passing through a capillary bed entirely. Let's look at the physiology of blood flow. The hemodynamics refers to the physiology of blood flow in the cardiovascular system. Okay, first you have to understand some basic concepts though. Gradients are what drive most processes in the body, whether you're talking about concentration gradient, pressure gradient, or electrical gradient. Your heart is what provides the force that drives the blood through the blood vessel, and it creates a pressure gradient. So therefore your pressure is greatest near the heart, and then it starts to decrease as the blood flows away from the heart. So your blood will flow down this pressure gradient from an area of higher pressure near the heart to an area of lower pressure in your peripheral vasculature. That's the reason it's important to take a blood pressure closest to the heart, location of the heart, which is your left arm, your brachial artery of your left arm. That's the standard blood pressure vessel that's usually measured. So blood pressure is the outward force that blood exerts on the walls of the blood vessels. It's expressed in units of millimeters of mercury, which is the force exerted by a column of mercury, 1 millimeter in height. Blood pressure will vary dramatically in different parts of your vasculature. It's highest in your large systemic arteries and lowest in your large systemic veins. And that's because the veins are your more compliant vessels. Your magnitude of the blood pressure gradient is your main factor that determines your blood flow, or the volume of blood that flows per minute. Generally, blood flow will match its cardiac output, which averages between 5 to 6 liters per minute. Blood flow is said to be directly proportional to pressure gradient. That means that when blood flow increases, then pressure gradient increases, and vice versa. Any factor that determines blood flow is resistance. Another factor that determines blood flow is resistance, defined as any impedance or hindrance to blood flow. Blood flow is said to be inversely proportional to resistance. That is, as resistance increases, blood flow decreases, and vice versa. Velocity with which blood flows is largely determined by the total cross-sectional area of the blood vessel. So as your arterial system branches into more progressively smaller blood vessels, your total cross-sectional area increases. Therefore, your capillary beds will have your largest total cross-sectional area. Therefore, your velocity of blood flow is slowest in your capillary beds and fastest in your aorta. Area, we define area as a mathematical calculation of the area of a circle made by the cross-sectional A for area, which equals to pi times the radius of a circle squared, or A equal pi r squared, as you remember from your high school days. So the radius of an arterial or a capillary is quite small, so the cross-sectional area of a small vessel will also be small. But remember, those small capillaries are far more numerous than your larger vessels with a larger cross-sectional diameter. Therefore, your total cross-sectional area of your smaller vessels is much greater than that of your larger vessels. You can see that in this little illustration where the total cross-sectional area of the artery, and then once it branches into the 5 smaller branches, even though they're smaller individual areas, you add the sum of all 5, you get 10 centimeters squared, which is twice that of your entry point of your artery, which is only 5 centimeters squared. So your velocity will decrease as your area, cross-sectional area, increases, because your same volume of blood is now filling the equivalent of a much larger container. Therefore, your blood is spread out over a wider area as your vessels branch, causing it to flow more slowly. And that's important because you need a slower velocity of blood flow to allow for more efficient gas and nutrient exchange in your capillary beds. So 3 factors that influence blood pressure: the resistance, cardiac output, and blood volume. Resistance is any factor that hinders blood flow through your vasculature, which then contributes to the overall resistance of that circuit. That's the reason vessels near the heart contribute little to overall resistance, while resistance is much greater further away you are from the heart. So in the body's periphery, your peripheral resistance will increase, so therefore your blood pressure will also increase with increased resistance. Another factor that determines resistance, another variable, is your radius of your blood vessel. The resistance will vary inversely with the vessel's radius. So as your radius increases or dilates, the resistance of blood flow will decrease, as you can see from the illustration. And then the third factor that affects resistance is the viscosity of the blood, as the inherent resistance that all liquids have to flow or being put into motion. So the more viscous, the more dense a liquid is, the more its molecules resist being put into motion and staying in motion. Therefore, blood has a relatively high viscosity because of its high number of proteins and cells. Remember, it has around 5 million red blood cells per cubic milliliter, and between 4,000 and 11,000 white blood cells per cubic milliliter. And that equates to a high number of cells. But it also has a lot of protein, and that overall increases the blood viscosity. The vessel length will increase resistance. The longer the blood vessel, the greater the resistance. Therefore, there's more pressure needed to propel blood through a long vessel than a short one. That's the reason your pulmonary circuit is so much lower than the resistance in your systemic circuit. So the length of the vessel contributes to resistance. The greater the length, the greater the resistance. And that's a direct relationship. Cardiac output. Cardiac output is a product of your stroke volume, the amount of blood pumped with each beat, times your heart rate, or the number of beats per minute. This is one of the main factors that affects your blood pressure. So your cardiac output and peripheral resistance are your 2 factors that determine your pressure gradient that drives your circulation through the body. And you can express that relationship with this mathematical equation. Delta P means the pressure gradient would equal your cardiac output multiplied by your peripheral resistance. So as your pressure change will then be caused by altering either the cardiac output and or the peripheral resistance. So when your cardiac output increases, your blood pressure increases, and when your cardiac output decreases, your blood pressure decreases. So the final factor that determines your overall blood pressure is the volume of blood in your circulatory system. Your total volume of blood is directly linked to the amount of water in the blood. So when blood contains more water, your blood volume increases. As your blood volume increases, like when you're not drinking water, your blood pressure will increase, and vice versa. So as your blood volume increases, your blood pressure increases. When your blood volume decreases, your blood pressure decreases. So you have small increases in blood volume. Those are going to offset by the ability of the vessels to stretch, and that property is known as compliance. Veins are your most compliant vessels compared to arteries, and that refers to the stretch to accommodate the added fluid when the blood volume increases, with only a small increase in pressure in your vessel. So vessels are much more compliant than your arteries. That means their pressure change will change little with change in volume. So these are all the factors that determine your blood pressure: blood vessel length, vessel diameter, viscosity. Remember, those affect peripheral resistance. Cardiac output is determined by stroke volume and heart rate. Remember, obstructions in vessels like atherosclerosis, those also will determine peripheral resistance. Okay, and then your water loss and water gain, those determine your blood volume. So you take your peripheral resistance, your cardiac output, and your blood volume. Those are your 3 main factors that determine your blood pressure. So your blood pressure remains fairly low throughout your pulmonary circuit, but your blood pressure will change dramatically as your blood travels through your systemic circuit. So your blood pressure in your pulmonary circuit is only about 15 millimeters of mercury, whereas in your systemic circuit it's about 95 millimeters of mercury. Now, your systemic arterial pressure is a pressure profile of your entire systemic circuit. It's highest in the aorta and elastic arteries, and then it starts to decline as it spreads throughout the muscular arteries. Your mean arterial pressure is the average pressure in the systemic arteries during an entire cardiac cycle, and it generally measures about 95 millimeters of mercury. Remember, your heart has both contraction and relaxation periods, or systole and diastole. So your pressure gradient generated by the heart will pulsate. So it increases during ventricular systole, or contraction of the ventricles, and then declines during ventricular diastole. And that leads to two separate pressures in the arteries. Your systolic pressure averages about 120 millimeters of mercury. Your diastolic pressure generally averages about 80 millimeters of mercury when a person is at rest. So the difference between your systolic and diastolic pressures, which is about 40 millimeters of mercury, is called the pulse pressure. So you can measure your arterial blood pressure in the arm with an instrument called a sphygmomanometer, or blood pressure cuff, and a stethoscope for auscultating, listening to the heart sounds. So you can't directly measure mean arterial pressure. So it's approximately equal to your diastolic pressure plus 1/3 of your pulse pressure. And your pulse pressure is your difference between your systolic and diastolic pressure. So let's say if your diastolic pressure is 80 millimeters of mercury, and your pulse pressure is systolic minus diastolic, or 120 minus 80, which would be 40, your pulse pressure would be 40 millimeters of mercury. You take your diastolic pressure, which would be 80, plus 1/3 of 40, which is your pulse pressure. So you take 80 plus 1/3 of 40 would be 13, and so you get a mean arterial pressure of about 95 millimeters of mercury. And that's an average mean arterial pressure. So that takes into account your ventricular systole and your diastole phases of your cardiac output. Your pressure doesn't change much in your pulmonary circuit. It remains fairly low from the pulmonary artery all the way to the pulmonary veins. But as you can see from the chart, the pressure does change significantly as your blood travels through your systemic circuit. It goes from the major arteries, muscular arteries, from 120 over 80, average about 95, down to about 80 in the arterioles, to about 35, where the arterioles meet the capillary beds. So you get a drop of 80 to 35. That's your most dramatic drop in pressure. Okay. Capillaries, they go from 35 to 15. 35 would be at the arterial end of the capillary, 15 would be at the venule end. Venules have a pressure change between 15 down to 5, and then the large veins like the vena cava, they'll be about 5 to 0 millimeters of mercury. So your systemic capillary pressure is the pressure at the arteriolar end of a capillary bed. It's approximately the same as that in the small arterioles, which is about 35 millimeters of mercury. So at the venule end of a capillary, the pressure drops to 15. And that pressure decreases mainly due to the reduction in blood volume because water is filtering out of the capillaries into the tissues. So this shows you the blood pressure in different portions of the circulation. From the aorta, you can see where the mean arterial pressure is about 95. Then you go to the arterioles, to the entry of the capillaries, where you get a drop between 80 to about 35, and then at the capillary you go from 35 to about 15, and then the venules you go down to about 5, and the large veins from 5 to 0. Okay. So your pressure drops in the venules and the veins, drops to about 4 millimeters of mercury in the inferior vena cava and about 0 millimeters of mercury in the right atrium. And the reason you have such a low pressure is mainly due to the high compliance of the veins and the dropping resistance as your vessels merge and become larger. So your venous blood, though, must be returned to the heart at the same rate that it's pumped into the arteries. And also your venous circuit is under such low pressure, though, there's not much of a driving force to propel venous blood back to the heart. So it has other factors. One of the factors that ensures blood return back to the heart are one-way valves, which prevent backward flow in your veins, especially your deep veins. Also, you have some smooth muscle in your vein wall that can contract under sympathetic stimulation to increase rate of venous return. Another factor are your skeletal muscle pumps, which your skeletal muscle pumps are your skeletal muscles surround your deeper veins of your upper and lower limbs. And so when your muscles contract, it squeezes blood in the veins and then pushes it upward toward the heart as they contract and relax. You can see from this illustration, when the muscle contracts, the blood's squeezed upward, and that pushes the valve open. Whereas when the muscle relaxes, the blood flows backward and the valve closes. That ensures that you have forward movement of your venous blood flow. The respiratory pump also helps propel blood through the thoracic and abdominal cavity veins. And that's also driven by eurythmic changes in pressure in both your thoracic and abdominal pelvic cavities. And that occurs with ventilation. During inspiration, you have a higher pressure in your abdominal pelvic cavity. That creates a pressure gradient that pushes blood in the abdominal veins upward. And that low pressure in your thoracic cavity allows your thoracic veins to expand. And then during expiration, the abdominal veins expand and fill with blood while your thoracic veins are squeezed. Okay. Varicose veins. This is a condition that's characterized by dilated, bulging, and often very hardened veins. They're often located in the superficial veins of the lower limb, especially in occupations where there's long-term standing on your feet all day long. Any condition that decreases rate of venous return, like pregnancy, standing upright for prolonged periods, abdominal obesity, that can cause blood to pool in the veins of the lower limb. And there also seems to be a genetic predisposition to varicose vein development. It runs in families. Remember, your lower limb superficial veins are not supported by those skeletal muscle pumps. So that extra blood volume will stretch those vessels and cause those enlarged regions that are visible beneath the skin. That's what causes the bluish discoloration in the lower extremities. Also, you have high pressure in the abdominal pelvic cavity during defecation or childbirth. That will in turn decrease the return of venous blood from the anal veins. These are also superficial and not well supported by the surrounding tissues. That causes these vessels to weaken and dilate because of this high pressure. Those are what we refer to as hemorrhoids. Blood pressure maintenance. So your mean arterial pressure has to constantly be maintained at about 95 millimeters of mercury. Any deviation from 95 triggers mechanisms from your nervous, endocrine, and your urinary systems. These also act to raise your blood pressure, restore it back to its normal level. Your short-term controls of blood pressure are mainly controlled by your nervous system and your hormones of your endocrine system. Your short-term effects are generally achieved mainly by adjustment of resistance and cardiac output. So your sympathetic nervous system, your main branch of your nervous system control of hemostasis, both your autonomic divisions, your sympathetic and parasympathetic, have immediate effects on blood pressure. Your sympathetic axons release norepi and epi into your cardiac muscle cells, as well as smooth muscle cells of your blood vessels. And it produces two immediate changes. One, they both increase blood pressure. Increase in heart rate and contractility will increase cardiac output. Constriction of all types of vessels, especially your arterioles, that increases peripheral resistance. So this shows you a summary of your sympathetic neurons, increasing heart rate and contractility, which then does increase cardiac output, as well as sympathetic neurons causing vasoconstriction of the arterioles, which does increase peripheral resistance, because remember, you reduce the diameter, that increases resistance. Your parasympathetic system, mainly via the vagus nerve, releases acetylcholine onto the cardiac pacemaker cells, mainly the SA and the AV node, as well as the atrial cardiac muscle cells. And that in turn decreases blood pressure by slowing the heart rate and decreasing cardiac output. The baroreceptor reflex. This is a negative feedback loop that responds to any increase in blood pressure. And its protective mechanism the opposite feedback loop will occur if your systemic blood pressure decreases. Your receptors, especially in your neck and your carotid artery, the aortic bodies, those receptors detect less stretch and rate of depolarization of the receptor decreases, In response, the medulla stimulates your sympathetic nervous system to increase blood pressure. So basically, your stimulus is the blood pressure increasing above its normal range. The baroreceptors and the carotid signs detect this increased pressure, and the action potentials are going to fire at a faster rate. The impulses then travel to the medulla, the brainstem, for integration. The parasympathetic neurons in the medulla then inhibit any sympathetic activity, which induces vasodilation and a decreased heart rate, and that will then lower your cardiac output. Okay, by dilating the blood vessel and also lowering the cardiac output by inhibiting any sympathetic activity, so it'll lower the heart rate. And that will in turn cause the blood pressure to decrease, and your feedback will decrease the response from the medulla as those conditions return to normal. The opposite event is when the blood pressure drops. Now the baroreceptors, the carotid sinus, will detect this decreased pressure and then lower the rate of firing. The impulse then travels to the medulla for integration. Now the medulla increases sympathetic activity, okay, and decreases parasympathetic activity. And that in turn increases heart rate and contractility and also allows for vasoconstriction. And that's how you can keep this blood pressure returned back to its normal level, increase it back to its normal level, and your feedback return to the medulla is then returned back to normal. You can test the baroreceptor reflex by doing a maneuver called the Valsalva maneuver, where a subject bears down and tries to blow out or expire against a closed glottis, airway in the larynx. And that's what occurs when you cough or sneeze, defecate, or heavy lifting. What that does, it raises pressure in your thoracic cavity and thus reduces return of venous blood flow to the heart. In turn, that causes a drop in blood pressure, and that should trigger your baroreceptor reflex and generate a subsequent increase in heart rate. Okay. Then you have your effects of your chemoreceptor stimulation as another short-term maintenance of blood pressure. Your peripheral chemoreceptors, they primarily play a role in regulation of breathing, but they also affect blood pressure. These receptors respond mostly to oxygen levels in the arterial blood. The central chemoreceptors, like in the brainstem, respond to decreases in pH of the interstitial fluid in the brain. And that triggers another feedback loop that indirectly increases activity of your sympathetic neurons and results in a vasoconstriction and thus an increase in blood pressure. So your endocrine system will work with your nervous system, okay, to maintain all aspects of homeostasis, including blood pressure. Even though your hormone response is much slower, let's look at some of the endocrine system short-term regulation of blood pressure. Hormones that control cardiac output are epinephrine, norepinephrine, thyroid hormone. Epi-norepinephrine, released from the adrenal medulla, causes vasoconstriction, which thus increases peripheral resistance, which thus elevates blood pressure. Angiotensin II is a constrictor, powerful vasoconstrictor. ANP stands for atrial natriuretic peptide, causes a mild decrease in peripheral resistance, as well as causing sodium and water excretion by the kidneys. Your long-term maintenance of blood pressure mainly falls to your urinary system and certain hormones of your endocrine system that affect the kidneys. They basically control blood pressure by either increasing or decreasing the amount of body water lost as urine, which then affects blood volume. The endocrine system regulates your blood volume mainly through the release of ANP and angiotensin II, as well as ADH and aldosterone. So when your blood pressure increases, the atrial cells in the right atrium secrete ANP. That causes the kidneys to excrete more water and sodium. And that will decrease blood volume and therefore your blood pressure. When your blood pressure decreases, the ADH secretion will then trigger your thirst drive and increase the amount of water retained by the kidneys. That in turn raises your blood volume and your blood pressure. Renin secretion from the kidneys triggered when your blood pressure drops. That first begins a process that activates the production of angiotensin II. That induces your thirst mechanism, which causes sodium retention. As a result, increases blood volume. So renin is secreted when your blood pressure drops or blood volume drops by the kidneys. Okay. Renin causes the conversion of angiotensinogen to angiotensin 1 in the liver. Angiotensin 1 then converts to angiotensin 2 by angiotensin converting enzyme in the lungs. It also induces your thirst and sodium retention, which increases blood volume. Angiotensin 2 also triggers aldosterone secretion from the adrenal gland, which causes retention of sodium, and thus water will follow the sodium from the kidneys, and that increases blood volume. So let's look at the urinary's long-term control over blood volume. If your blood pressure increases, there's more water flowing through your nephrons in your kidneys. And what those cells can return back to the blood. So water is then lost for the body as urine, and therefore your blood volume and blood pressure will also decrease. If your blood pressure decreases, then less water flows through the kidney tubules. And those cells have more time to reclaim water and return it to the blood. That results in a decreased urine production, but a slight increase in blood volume and pressure. So your maintenance of your blood pressure by your nervous, endocrine, and your urinary system is basically effects on each of these factors that impact blood pressure, which are blood volume, peripheral resistance, and cardiac output. So this basically goes through those mechanisms affecting peripheral resistance, both endocrine and neural, mainly by causing constriction, thus increasing resistance. Endocrine, decrease renin, or neural, increase parasympathetic or decrease sympathetic. That will in turn decrease peripheral resistance by dilating the vessel. And then you have your cardiac output mechanisms. Endocrine will be thyroid hormone, epi and norepi. And your neural would be increased sympathetic activity or decreased parasympathetic. Those in effect increased rate and forced contraction. And then your endocrine system is A&P hormone. And your neural mechanisms are your decreased sympathetic activity, but increased parasympathetic activity, which will in turn decrease the heart rate. They say the heart rate is reduced 25 beats per minute, mainly by the parasympathetic activity from the vagus nerve. Okay, and then your endocrine system affecting blood volume would be through the hormones angiotensin 2, ADH, and aldosterone. And your renal mechanism is increased water retention. Those three factors will increase blood volume, thus your blood pressure will be increased. And the endocrine system through the release of A&P, and your renal mechanism through the decreased retention of water will cause a decreased blood volume. Okay. And that will serve to reduce blood pressure. Basically, carotid sinus massage is performed by massaging the skin over both carotid sinuses simultaneously. What that does is initiates the baroreceptor reflex artificially in an emergency setting to reduce dangerously high blood pressure. She was used routinely in the ER when you have a person that comes in with refractory hypertension, when the brain is in danger of herniating. So in the AP lab, you should never do that, though. You should never try to feel the pulse in both carotid arteries at the same time, because you could actually perform a carotid sinus massage. That can cause a sudden drop in your lab partner or patient's blood pressure, and the person could actually lose consciousness. Okay, disorders of blood pressure, hypertension and hypotension. Essential hypertension, we really don't know the cause, and that's the majority of the causes of hypertension. Secondary hypertension is when you know the cause. Okay, like an adrenal tumor, like a pheochromocytoma of the adrenal glands, or atherosclerosis causing occlusion of your blood vessels. Hypotension, defined as a systolic pressure lower than 90 or diastolic lower than 60. It's only diagnosed, though, if the individual shows symptoms. It's actually beneficial to have a lower blood pressure, okay, if you're not showing symptoms. Severe hypotension, called circulatory shock, can lead to loss of consciousness, syncope, and organ failure. Your blood pressure is insufficient to deliver oxygen and nutrients to your cells, and it can be rapidly fatal. Most common cause for hypotension is reduced blood volume. That's called hypovolemia. That can occur because of blood loss, fluid losses from diarrhea, vomiting, overuse of diuretics like Lasix, insufficient fluid intake. Severe blood loss can lead to hypovolemic shock, and that is generally fatal unless the blood volume is immediately restored with IV bags. Severe hypotension, a decrease in heart rate can result in hypotension, and generally it's due to medications that are prescribed to treat hypertension, like your beta blockers. A decrease in stroke volume is most commonly caused by heart failure, which is the inability of the heart to function efficiently as an effective pump. Severe heart failure can also produce drops in cardiac output, and that condition is referred to as cardiogenic shock. Also, you can have excessive vasodilation, which can produce profound hypotension. There's many conditions that can potentially cause excessive vasodilation, including antihypertensive medications, abnormalities in the autonomic nervous system functioning, or a decrease in blood pH, acidosis. Another potential cause of excessive vasodilation, which is generalized, is release of the chemical histamine into the blood during a severe allergic reaction. That's called anaphylactic shock. Also, you can have excessive vasodilation with bacterial infections of the blood, like septic shock. Those carry a very high mortality rate. I think it's 85% for septic shock of death. So remember, your capillaries are found in clusters called capillary beds. They wind their way through the cells and the tissues of the body. So your blood flow to a tissue through a capillary bed is what we refer to as tissue perfusion. It's tightly regulated, mainly to ensure that metabolic needs of all tissues are met at all times. Remember, capillaries are extremely thin. The vessel walls are only 2.2 micrometers in thickness. A capillary consists only of an endothelium rolled into a tube and a small amount of basal lamina, and it's secreted by the endothelial cells. Parasites are cells found around some capillaries, and they do have contractile filaments that appear to control blood flow through the capillary. You see this in the parasites that surround your capillaries in your brain, in your blood-brain barrier. Capillaries average about 50 micrometers in length and about 8 to 10 micrometers in diameter, just a little bit larger than a red blood cell, which is about 7 to 8 micrometers. Most of your capillary walls are 1 to 3 endothelial cells joined by tight junctions that surround the capillary's lumen. This is a generalized capillary on the left, showing the endothelial cells with tight junctions and the basal lamina. And then a photomicrograph of a capillary showing you these red blood cells in single file. That's called a roulette formation. These are the adipocytes, the fat cells, neighboring this particular capillary. So nutrients, gases, ions, and waste have to be able to cross the wall and travel between the blood and the capillaries and the tissue cells. So the movement of these materials is what we refer to as capillary exchange. There's generally 3 mechanisms: 2 types of diffusion and transcytosis. So some capillaries have small pores within their cells called fenestrations. Remember, the 2 types of passive transport are diffusion and osmosis. Remember, water, as well as your smaller substances like monosaccharides and amino acids, these are generally dissolved in water. So they're able to really move through the fenestrations when you have a gradient. Lipid-soluble molecules like oxygen, CO2, and lipids, those generally enter and exit the capillary by diffusing across the membrane on one side of the endothelial cell and then out the membrane on the other side. And then the substances either enter the interstitial fluid or the blood. The larger molecules have to cross endothelial cells by transcytosis. And the molecules that are taken into the cell by endocytosis, then they're moved out the other side of the cell by exocytosis. But both processes, diffusion and transcytosis, those both involve a substance crossing the entire width of the endothelial cell. So those are your 3 mechanisms. So continuous, fenestrated, and sinusoidal. Okay. This table 18.3 shows you the continuous, like in the skin, your nervous connective tissue. They have a lot of tight junctions. They're the least permeable, the least leaky. Okay, and that's because they're not really known for exchange of nutrients. They're mainly noted for like the blood-brain barrier in the brain or in the skin for temperature regulation. Also, you have fenestrated capillaries, these little windows, kidneys, endocrine glands, and small intestine. They're moderately leaky, so they allow larger volumes of fluid and larger molecules to cross the capillary wall. And then you have your leakiest capillaries, which are your sinusoidal capillaries, like in the spleen, in the liver, the bone marrow, as well as your lymphoid organs. They're leakiest. They allow larger substances of the cells to cross the capillary walls. So you see these in places like the spleen, where your red blood cells are degraded, okay, or your medullary cavity. So continuous capillaries, the muscle, skin, nervous, and connective tissues, least leaky because they have a lot of tight junctions where you have fewer substances entering or exiting the blood by paracellular routes. Then you have the fenestrated, which are intermediate, okay, like in the kidneys. These are going to be located places that require substance to rapidly enter or exit the blood. And then you have the leakiest sinusoidal capillaries, because they sometimes just called sinusoids. Discontinuous sheet of endothelium, an irregular basal lamina, and large porous. In the endothelial cells, typically 3 to 4 times larger in diameter than are your other capillaries. They often have an irregular shape because their boundaries are determined by whatever organ that they reside. So liver, spleen, lymphoid organs, and bone marrow. Those are all going to contain sinusoidal capillaries. Okay. This next part of the chapter talks about the structure of and blood flow through a capillary bed, tissue perfusion. I'll let y'all read this on your own. This basically shows you a capillary bed with a thoroughfare channel, and these capillaries will have these sphincters. Thoroughfare channel will lack the precapillary sphincters, these little valves. When the sphincters close, the blood flows straight from the meta-arteriole to the thoroughfare channel and into the venule without passing through the true capillaries. And blood does not flow backward into the true capillaries from those thoroughfare channels. And that's because you have a pressure gradient that favors movement of the blood in one direction. So here you got the precapillary sphincters closed so that the blood flow is not being transferred to the capillary bed. Okay. So there's 2 mechanisms that help. Tissue perfusion is regulated by local factors within an individual tissue, and that phenomenon is called autoregulation. There's 2 types of autoregulatory controls, myogenic and metabolic. Myogenic is going to counter a change in blood flow by altering the arterial resistance. Remember, your velocity of blood flow is related inversely to resistance. So if resistance increases, velocity decreases, and vice versa. Your mechanism will slow blood flow by increasing resistance when your arterial pressure increases. That mechanism then will speed up blood flow by decreasing resistance when the arterial pressure lowers. So it can get more blood to the area. But both changes will help maintain your local tissue perfusion at a constant level. And what that does ensures that gases and other substances continue to be exchanged in adequate amounts, even in the face of fluctuating blood pressure. Your metabolic controls are mediated by chemicals present in the interstitial fluid surrounding the capillaries. And it's mainly the chemicals that are the result of your cellular metabolic activities, like generating energy, ATP. So in cells that are producing ATP rapidly, like actively contracting skeletal muscle, low concentration of O2 and high concentration of CO2, carbon dioxide, and hydrogen will cause smooth muscle cells of the arterioles to relax, dilating the arterioles, which increases perfusion, and that ensures you have enough oxygen and nutrient delivery to your actively metabolizing cells. In cells that are at rest or producing ATP slowly, you'll have high concentrations of oxygen and low concentration of CO2 and hydrogen, and they cause constriction of those local arterioles, and thus a decrease in tissue perfusion. So if you look at this, each organ has its own unique requirements in terms of blood flow and necessary nutrients. Heart receives about 5% of your total cardiac output from the coronary circulation. But the perfusion pattern through your coronary circulation is the opposite of the rest of the systemic circuit. Your heart tissue perfusion will decrease during systole, which is the opposite with most of the other organs. Your main local autoregulatory mechanism for cardiac muscle tissue are metabolic controls, and particularly the concentration of oxygen in your cardiac interstitial fluids. Low fluid oxygen levels in the interstitial fluid will trigger vasodilators, chemicals like nitric oxide, which directly dilate the arterioles serving the myocardium, and that greatly increases perfusion. Brain is extremely intolerant of ischemia. Ischemia is a generalized weakening of the cells. So a sudden decrease in tissue perfusion to the brain will result in a loss of consciousness within seconds. So your brain accounts for only 2% of your total body mass, but it receives about 15% of your total cardiac output. So your biogenic and your metabolic controls, those autoregulatory mechanisms, they'll help maintain cerebral blood flow at a nearly constant rate, about 750 mils per minute. Even though you have a constant blood supply, your blood flow within the brain to the different areas will vary considerably with neuronal activity. So in part due to the standard metabolic controls, your brain areas will have a higher activity, will consume more oxygen and produce more CO2. Also, that you have certain neurotransmitters that are direct vasodilators. Others can act on astrocytes, the neuroglial cells, in contact with the cerebral arterioles. So when stimulated, the astrocytes then induce production of vasodilators, and that opens up the arterioles, and that thus increases tissue perfusion to those active regions of the brain. So your skeletal muscle, your blood flow can change dramatically in skeletal muscle tissue during exercise, and that can increase as much as 50-fold, and that's called hyperemia. The mechanism behind hyperemia basically lies in the structure of the arteries supplying the skeletal muscle. As you can see, they have a feed artery that eventually leads to terminal arteries. So during resting conditions, the resistance of feed arteries is high, and your terminal arteries are constricted. That limits tissue perfusion. But when you begin exercise, your metabolic conditions around your skeletal muscle will dilate those terminal arterioles. What that does produce a small increase in tissue perfusion as more capillary beds open up, but not enough of an increase to meet the demands of your vigorously working skeletal muscle. As you continue exercise, your vessels proximal to the feed arteries, to the terminal arterioles, will also dilate, and that dramatically increases tissue perfusion. You get this progressive, stepwise vasodilation, which allows your skeletal muscles to precisely match the perfusion to the degree of exercise. Your skin, your largest organ in the human body, your blood supply is located in the dermis. Therefore, the oxygen and nutrients must diffuse from the capillaries of the dermis to the epidermis. So your autoregulatory controls of your skin's blood flow. It occurs in response to temperature. So that's the reason when you place something warm directly on the skin, it causes instant vasodilation. And whereas cold will produce vasoconstriction. So, but your most important control of your skin's blood flow is from the sympathetic nervous system. Those neurons that regulate your blood flow in the skin as part of your thermoregulation. Also, your sympathetic nervous system alters skin perfusion via vasoconstriction to conserve heat or dilation to release heat. Okay, I want to just go briefly and look at the capillary pressures that work in a capillary. There's two basic pressures that drive water movement within a capillary: hydrostatic pressure and osmotic pressure. They promote movement in the opposite direction. Hydrostatic pressure drives water out of the capillary. Osmotic pressure generally draws fluid into a capillary. Hydrostatic pressure is defined as the force that a fluid exerts on the walls of its container. Of course, the container and the vessels are the vessel walls. So remember, blood is a fluid in a vessel that's creating hydrostatic pressure from water. Therefore, your blood pressure is equal to hydrostatic pressure. So remember, fluid always flows from a higher pressure, a higher hydrostatic pressure to an area of lower hydrostatic pressure through your capillaries until that gradient is then extinguished. This passive process is known as filtration. So your hydrostatic pressure in the capillary will change from the arterial end, where it measures 35 millimeters of mercury, to the venular end, where it measures 15. Your hydrostatic pressure of your interstitial fluid is very low, so it's functionally 0 millimeters of mercury. So there are steep hydrostatic pressure gradients on both ends of the capillary, and these are what drive water out of the capillary and into the interstitial fluid. So this would be at the arterial end, where you have your dominant hydrostatic pressure driving water out of the capillary. Okay, right in the middle, the hydrostatic pressure is 0, and at the other end, the venular end, your hydrostatic pressure is dropped to 15 millimeters of mercury. So you've dropped 20 millimeters of mercury, and that's mainly through filtration. So remember, osmosis, it involves movement of water from a solution with higher or with lower solute concentration to one with a higher solute concentration. And the number of solute particles in solution determines osmolarity, osmotic concentration. So the greater number, the greater the osmolarity. So the solute particles in solution exert a force or pull on the water molecules. That's called osmotic pressure. It's determined mainly by the number of particles, not the size. So your osmotic pressure of your capillary bed is about 25 millimeters of mercury, and it's almost exclusively created by large proteins like albumin that's made in the liver. Remember, proteins are too large to leave the capillary, so your osmotic pressure remains relatively constant throughout the capillary's length, and therefore your osmotic pressure is low in your interstitial fluid. So that difference in osmotic pressure will create an osmotic pressure gradient. That's called the colloid osmotic pressure, or oncotic pressure. So colloid osmotic pressure always draws water into the capillary by osmosis. Okay, so here's your little diagram showing you the hydrostatic and osmotic pressures in the capillary blood and the interstitial fluid. Okay, so if your hydrostatic pressure is higher than your osmotic pressure, like at the arterial end of a capillary, the water then leaves the capillary by filtration. On the other hand, if the osmotic pressure is higher, which is 25, then your hydrostatic pressure, which is 15, then the water will then enter the capillary by osmosis, which is what you want to happen at the venular end of a capillary. So your capillary net filtration pressure is the colloid osmotic pressure and your hydrostatic pressure gradient driving water in the opposite directions. Your hydrostatic pressure pushes water out of the capillary. Colloid osmotic pressure pulls water into the capillary. The difference between those two pressure gradients is the net filtration pressure. So you take your hydrostatic pressure of 35, subtract the colloid osmotic pressure of 22, and you get 13. That gives you your net filtration pressure. And that's the force that drives water out of the capillaries by filtration. And that's because your hydrostatic pressure is greater at that end. So this is the net filtration pressure in capillaries. Edema is a condition characterized by excessive amount of water in the interstitial fluid. Common cause of edema include increase in capillary hydrostatic pressure gradients secondary to hypertension, or a decrease in colloid osmotic pressure like liver disease or cancer or starvation. Peripheral edema is Pronounced edema found in your hands and feet, where the diastolic pressure gradient is already slightly higher due to the effects of gravity. You also can see profound edema from decrease in colloidal osmotic pressure, whereas the excess water tends to accumulate in the interstitial fluid of the abdomen. That condition is referred to as ascites. We'll stop there. Stop here, and that will conclude Chapter 18, Anatomy of the Systemic Arteries.